Hello again. This is Dr. Mark Prats, and this is another edition of Beyond the Aid Bag, our critical thinking series for our U.S. Air Force IDMTs. So, in this talk, we're going to go through a case of a patient that's coming in with an acute headache and walk you through some of my thought processes of how I think through these cases and some of my tips for how to manage these patients. So as always, our initial slide, just to let folks know that these are really just my views. They don't necessarily reflect official policy of any of my employers. There are no particular products that I'm endorsing, and so I don't have any financial conflicts at this time. The goal of this presentation is to help teach you to continue to build your skills at creating these differential diagnoses lists based on a chief complaint. We'll talk a little bit about what red flag symptoms are for this particular chief complaint, identify some key findings within this patient's history and physical exam that point us in one direction versus another. We'll refine that differential diagnosis based on our findings and then develop a plan for any additional evaluation or management of this patient's acute complaint. And talk a little bit about what things we need to let them know to watch out for that would indicate a need to return to see us sooner rather than later. So our patient here is going to be a 35-year-old master sergeant. They're a load master as far as their career field goes. And they're coming in and they're going to let you know they've been having this pounding headache for like the last 12 hours. So before we delve into any questioning or examining of this patient, I want to reference back to what will be a part of the newest IDMT protocol book as soon as we do publish it, sometimes here in the near future. For those IDMTs that have just recently graduated from the schoolhouse, you may have seen this before, but what we've done to try to help you guys build these differential diagnoses lists is give you kind of a cheat sheet starter. And so what you see here is a example of a differential diagnosis list that we created for our IDMTs. And each one of these lists is broken up into three different sections. The three sections are diagnoses that you cannot miss. Now, these are diagnoses that, if not dealt with immediately, can either cause harm or even death to your patient. And so you need to find ways to completely rule out or manage these conditions before the patient leaves your examining area. More common conditions are those that obviously are going to show up more often than not. These may or may not be as serious as those can't miss conditions. And lastly, there's an other section where we kind of put your zebras, your diagnoses that you should think about but don't happen very often, but maybe they're not the most dangerous thing if you were to miss it at that point in time. So for this patient that's coming in with a headache, this should be kind of where you're starting from with your differential diagnosis list at a bare minimum. So can't miss diagnoses that you need to think about are things like tumors, clots, bleeding, masses around the brain, some inflammatory conditions that we may not have discussed while you're at the schoolhouse, like temporal arteritis, traumatic brain injuries and concussions that require specific return to duty protocols to prevent service members from having long-lasting sequelae from these injuries. Hypertensive emergencies, which require immediate medical intervention. A headache may be the only presenting symptom of the patient in these cases, although usually there's going to be some other symptoms along with their hypertensive emergency. You have to think of other organ systems too. Glaucoma, that increased pressure of the globe itself could be could present with a presenting symptom of a headache. Some more common things that we'll talk about are what I call primary headaches, or these are headaches for headache's sake, like migraines and tension headaches and cluster headaches. Sinusitis may be something that is much more commonly seen in our clinics that you're going to want to think about. Delving into that other section, could they just have a different acute illness, like they have the flu or um, a cold that seems to be causing them to have a headache that might fall more along the lines of a tension headache potentially. There's conditions like idiopathic intracranial hypertension, which I know we didn't talk about at the schoolhouse, but something that usually presents as like a chronic headache syndrome. There are folks that use medications on a regular basis. We always warn them the continued and frequent use of some of these over-the-counter pain medications can result in what we call a medication overuse headache. And then there's your dental, ENT, musculoskeletal type of issues like TMJ or dental pain that might present as a headache in some patients. Let's go ahead and build our initial differential diagnosis just based off of that chief complaint in our patient. So like I mentioned, one of the more common reasons for folks to come in with a headache are going to be what we call these primary headaches. And your main job in evaluating a patient that comes in with an acute headache is, first of all, to determine whether or not this headache falls into one of two categories. And that's either that primary headache category, those headaches for headache's sake that usually don't cause immediate or long-term harm to the patient, or is it a secondary headache or a headache that is a symptom of another condition that could be causing severe harm to your patient in the near term. So things that are included in that primary headache category, like we mentioned, tension type headaches, migraine headaches. Those migraine headaches might be with an aura or a neurologic sensation that usually precedes the headache. These migraine headaches may be what we call complex, where they present with neurologic symptoms that are persistent through the time that they have the headache and often can mimic strokes. A lot of times people have the same type of complex migraine presenting with things like weakness or paresthesias. It's important to know if the symptoms that the patient is having are the same as the symptoms they've had with prior migraine headaches, because that might indicate that this is more likely a complex migraine. But when in doubt, you should always hunt for that stroke as a source of the headache and symptoms if you're unsure. And lastly is the cluster headache, which is a primary headache that's often seen more often in males. That can be pretty severe and devastating to those that suffer from them. Looking at secondary headaches, really these are the headaches that are going to be the symptom of either an infection, like a encephalitis, meningitis, or intracranial abscess, a bleed of some kind, some sort of mass, or might call it a Goomba, if you don't really know what it is at the moment when you're looking at a CT scan. Or is it related to a toxin, medication, or poison? Were they exposed to carbon monoxide? Or did they take too much of a particular medication, and this is the symptom of their overdose? So really, the first job in evaluating a patient that comes in with an acute headache is to determine, do they have a primary headache, or do you think that they have a secondary headache? And your questions and your exam finding or your exam procedures should drive that. Talking a little bit about red flag symptoms with headaches. And red flag symptoms in general, when it comes to medical conditions, are symptoms that may indicate things like cancer or bleeding, or really, like I mentioned, things that are going to cause the patient immediate harm if we don't do something about them right away. And so for headaches, we talk about these thunderclap headaches, these severe headaches that go from like 0 to 100 within a matter of seconds. These aren't headaches that gradually become the worst headache of your life. These are headaches that like start, and they start as the worst headache of your life. Some folks may present with red eyes and halos around lights, which could be an indication of something like a glaucoma. If they have systemic symptoms, from like an infection. Um, any headaches that are a new type of headache in an individual that's over the age of 50 would be concerning. Any neurologic symptoms that come along with a headache should be considered high risk for a condition that's going to cause the patient immediate harm and may require them to get evacuated or at least further evaluated at a higher level of care. Progressively worsening headaches are changing from their usual symptoms. And so if it's a headache that seems similar in location and quality, plus, maybe not severity, but definitely location and quality, you feel, more reassured. If it's started to change and it's different, that's a little bit more concerning to me in those cases. Headaches that change with position may indicate that maybe the patient has changes in intracranial pressure, may have too much or too little cerebrospinal fluid that might be contributing to the fact that they have a headache. And anybody that has severe hypertension along with the headache, that could be a sign of a hypertensive emergency and requires a little bit more immediate intervention in those cases. So our patient, so their headache, like we mentioned, started 12 hours ago. It started when they got home from work. It came on somewhat gradually over about a 30-minute period. The pain is worse when they're in bright lights or if they're exposed to loud noises. And it's improved when they just lay down nice and still and quiet in a dark room. They describe the headache as being throbbing or pulsatile. It's localized just to the right frontal region. It doesn't radiate to their neck or their back. At its worst, it's an 8 out of 10. At its best, it's a 6 out of 10. Now, whenever I'm trying to get an idea of pain scale, it can be pretty subjective from person to person. And so what you want to try to do is make it as objective as possible. So whenever I ask about pain with my patients, I give them the same scale. And it's a number scale, but it's also a relativity scale. And so I say, how's your pain on a scale of 0 to 10? 0, you have no pain at all. 10, you're going to pass out from the pain. And 5, the pain is so annoying that you can't get your mind off of it. And I feel like that gives patients a pretty good reference point to move from. And so this person's pain at best is pretty distracting at a 6 out of 10. And at worst, it's an 8 out of 10. I'm not going to quite pass out on you, but man, this is starting to become a pain that's pretty gnarly. So the pain's lasted for the last 12 hours. It's been pretty continuous. He took an 800 milligram Ranger Candy ibuprofen when he got home from work last night and hasn't really seen any improvement. So when we look at the things that the patient's told us, there are a few things that pop out to me that might indicate one diagnosis may be more likely than some other ones. And so some of the key things that were here is that it came on somewhat gradually, right? So we feel maybe a little bit better that this isn't a thunderclap type headache. The pain is worse in bright lights and when he's exposed to noises. We call that photophobia and phonophobia. And the pain's improved when he lays down in a dark room. The quality of the pain is described as throbbing or pulsatile, and it's in one kind of specific location on his head. All these things put together kind of point classically towards one diagnosis that we'll talk about here in a second. Some additional history that we get. So he has headaches periodically that are pretty similar. They happen less than once a month, so not too frequent, but definitely something that he deals with on a somewhat regular basis. He did not have any symptoms leading up to the onset of the headache. No recent illness type symptoms, no weakness or numbness, no vision changes, no speech difficulties, no changes in position other than the fact that it gets better when he lays down quietly, but it's not like sitting versus laying versus standing necessarily changes things for him. The headache doesn't change significantly with activity. We get a little bit worried about some vascular type of issues when people have headaches that are worse with coughing, sneezing, or activity. And denies any new activities, exposures, or trauma. It's a great question that I always ask patients whenever they come in with a new problem is, hey, this problem started, X days or X weeks ago. What was going on, just before that time? Did you change your diet? Did you change your activities? Did the stress at work change? What is it that maybe helped contribute to what's going on. And that can give you a really good idea of what you can do to help them move forward. Getting into our physical exam, pretty benign. So pretty normal vital signs for the most part. Maybe not the best blood pressure in the world, but he's pretty uncomfortable. He's kind of squinting his eyes in clinic. He wore his sunglasses in because he's having that photophobia. Cardiopulmonary exam that we do on every single patient that we see in an IDMT clinic was unremarkable. The key thing here at the beginning of our physical exam is kind of that squinting and wearing eyeglasses. That's a pretty classic picture for somebody that's having a pretty gnarly headache, migraine in particular. Continuing with our physical exam, again, not really much to go on here as far as findings. Unremarkable HEMT exam, neuro exams unremarkable as well, without any findings of weakness or sensory deficits. So kind of as we refine our differential diagnosis, trying to figure out if this is the primary or secondary headache, were there any red flag symptoms? Luckily for this gentleman, no. So we have a pretty low suspicion for a secondary headache. So that really narrows things down for us. So we've gotten down towards where we think it's a primary headache. So more likely than not, a migraine. Didn't really report any neurologic symptoms. So I'd say it's a migraine without an aura, or a tension type headache. Now, it's kind of tough to differentiate these sometimes because a lot of the symptoms overlap a little bit. You'll get some folks that have tension headaches that will have nausea. You'll get folks that have migraine headaches that don't have nausea, even though that's one of the diagnostic criteria that we'll sometimes use for migraines. So migraine headache is probably the most likely thing. It's pretty classic description of a patient presentation for a migraine. So what can we do for this patient? Well, we treat it pretty similarly to how we would treat tension headaches, and that's kind of the nice thing about where we got to in our differential diagnosis. Even if we guessed wrong on that 50-50, management-wise, we're going to do the right thing by the patient either way. So NSAIDs, like ibuprofen or naproxen, are going to be the mainstay of therapy. You might add something like an acetaminophen if they need to. They can take those at the same time if they want to. There's no problems with that usually, as long as they don't have any kidney or liver disease. Give them a little bit of rest, maybe 24 hours, 48 hours of bed rest or quarters if you're wanting to be a nice provider. And then try to help them identify any triggers that might be causing them to have these headaches. I always like to have folks keep what we call a headache journal to write down the things that they ate, the things they experienced in the minutes and hours before they had their headache onset, so we can identify those triggers and hopefully prevent them from having these headaches in the future. If this is somebody that's having a refractory migraine, so they've tried all the home remedy stuff and it's not working, and they're in there and they're like, "Doc, you just got to help me. You got to do something." We do have some options for them. So there are these triptan medications like sumatriptan that were designed specifically for migraine type headaches, and so you can try one of those. They're often either injectable or pills, or there's some nasal sprays as well, depending on what formulation your pharmacy has. And so you can talk to your medical preceptors about trying one of those triptans out. You can use those in conjunction with the NSAIDs. Oftentimes, the addition of an NSAID to a triptan medication has a synergistic effect, and patients will find those to be more effective. The other option, a lot of providers, especially in urgent care and ER settings, will have what they call a headache cocktail. One of the ones that I've found some success with is a little bit of IV fluid, some sort of IV pain medication. IV ketorolac tends to be the most common thing that we'll have in our clinics. You don't have to use a whole bunch of it. Often can get away with about 15 milligrams of the IV ketorolac. I would definitely not go any higher than 30. You use that in conjunction with a antiemetic. There's some pretty good research to show that metoclopramide, Reglan, is very helpful at aborting migraine headaches by itself. And so I'll often use that in conjunction with the fluids and the IV analgesics. The one thing you got to watch out for with the metoclopramide is that some folks will get these akathisias, this kind of like creepy crawly feeling. Folks that tend to be a little bit more on the anxious side seem to have a little bit of a higher risk anecdotally in my experience. Talk to your preceptors about things that you can do for that, or if you even want to do that medication. Sometimes they can be given a antihistamine like a diphenhydramine, which can help to smooth things out a little bit. And like I mentioned, you can always be nice and give them a little bit of quarters to try to get them through this acute time with their pretty bad migraine. So return precautions. So anytime anybody has any new neurologic symptoms along with their headache or development of those red flag symptoms, I don't want to have them come back. If their headache hasn't resolved in 48 hours, that's a problem, and that might mean that we're on the wrong track, and then we'd want to reinvestigate and see what other reasons why this person might be having a headache. So if they return, you should definitely be consulting your preceptor to determine if it's somebody that needs to go to the ED or be evacuated to get a more in-depth evaluation to include head imaging and some more laboratory evaluation. So to quickly recap, you have to always be building and refining your differential diagnosis list. Utilize the resources that we've given you to help build these lists and determine what's best for your patient. And make sure that before that patient leaves your side, that you've addressed all those red flag symptoms and that you've gone through that differential list and identified those things that are can't miss diagnoses. And you can feel with very strong certainty that those diagnoses are not what's causing your patient's symptoms. So this concludes another edition of Beyond the Egg Bag. I appreciate you guys listening. I look forward to talking to you again here in the future.